It's a very important topic. All the topics are important, but osteomyelitis is especially important both for your clinical and theory exams. It's very common that you'll get an osteomyelitis case in your exams. So what is basically osteomyelitis? Osteomyelitis is basically infection of the bone, right? Infection of the bone. Osteo means bone, and myelitis means probably it is bone marrow. Okay, so there are multiple meanings to this, but probably bone marrow. So infection of the bone and its marrow constitutes osteomyelitis, right? Osteomyelitis, infection of the bone, is very difficult to treat, and therefore it becomes a separate technique and a way in which you treat these patients with osteomyelitis. Okay, so what are some of the risk factors that you see in patients with osteomyelitis? You have some local risk factors, right? And then you have systemic risk factors. What are some of the systemic risk factors that you know of which cause osteomyelitis? One is diabetes, right? Immunocompromised patients of any kind, immunocompromised including AIDS, IV drug abusers, and sickle cell disease, and peripheral vascular disease, etc. Right. So these are all systemic factors which can cause, causal for osteomyelitis. Some of the local factors are open fractures, poor vascularity, poor skin condition, etc. are some of the risk factors for local risk factors for osteomyelitis. Okay. The spread. How do these spread? They can spread by inoculation, which is very common in trauma. Post trauma, there is inoculation of the bacteria, which causes direct inoculation of the bacteria, which causes osteomyelitis. The second most common way of spreading is a hematogenous spread. That means the bacteria or virus originated from the blood, and this happens because of a systemic disease, and very commonly in immunocompromised patients. The first form is inoculation or direct seeding of the bacteria, which happens in trauma and other conditions. Hematogenous spread, or through blood, where in systemic problems or immunocompromised patients, hematogenous spread can happen. This is the most common way in which it spreads in children. In pediatric age group, osteomyelitis occurs because of a hematogenous or a systemic infection. Which is the most common organism that causes hematogenous osteomyelitis? It is Staph aureus. Staph aureus is the most common organism. It doesn't matter what the mechanism of this thing is, but especially so in children and in hematogenous spread. In adults, the most common the location where the hematogenous spread occurs is in the vertebrae. In adults, it occurs in the vertebrae. So the third pathophysiologic mechanism in which it occurs is via direct, contiguous spread of the infection. Okay, this can happen because of previous surgery, sometimes adjacent trauma, and this is usually bacterial or fungal in nature. So the three forms of spread of origin of osteomyelitis is inoculation, very commonly in traumatic patients; hematogenous, through via the blood, very common in children. It is Staph aureus, and vertebra is involved in adults, and kind of contiguous because of previous surgery, trauma, or fungal infection. Right, all of us should know the biofilm formation in bacteria. Bacteria initially attach to an inert substance like a plate, inert substance like a foreign body like a plate or sequestrum, and they create a biofilm matrix or a biofilm. So now this matrix or biofilm is impenetrable to antibiotics and the systemic antibodies or other cells which can attack the bacteria and destroy it. They become impenetrable through this. So into this biofilm, no, except the bacteria, no other thing can enter, right? So this biofilm becomes protective for the bacteria, and it persists and becomes an infection, a persistent chronic osteomyelitis or infection. So what is this biofilm? It is an extracellular substance, usually a polysaccharide. It's an extracellular polysaccharide substance which prevents entry of antibiotics, antibodies, or other cells of the body which can defeat or destroy the bacteria. So it becomes impenetrable to those things. So what are some of the organisms, common organisms that occur in all of these age groups? This is very commonly confusing nowadays, but now it has been established beyond doubt in all age groups. Staph aureus is the most common organism which causes osteomyelitis. In the newborn, it can be group B streptococcus is also known second to Staph aureus. Group B streptococcus is known to cause second to Staph aureus. In children up to 4 years, Kingella kingae is one organism. Enterobacter species is another species of bacteria which can cause infection. In children or adolescents, you still have Staph aureus, but the second most common is H influenza. Previously, it used to be H influenza. Because of the availability of vaccine, H influenza osteomyelitis has decreased. In adults is invariably mostly Staph aureus. Okay, there are some special conditions where unusual organisms cause infection. All of us know Salmonella causes osteomyelitis in sickle cell disease. Pseudomonas infections are seen in IV drug abusers. Bartonella or cat scratch disease or cat scratch osteomyelitis is seen in AIDS or immunocompromised patients. Fungal osteomyelitis is seen in diabetes patients or immunocompromised patients. Right, so these are some of the unusual organisms associated with specific disorders. But even in these diseases, Staph aureus is the first organism, whereas these are the second ones which cause infection. So how do you classify osteomyelitis? You can classify osteomyelitis as acute, that is less than 2 weeks, where X-ray changes may not be seen. You will have to look up, find an ultrasound or MRI to see any changes. Then you have subacute, which is from 1 to few months, and chronic is after a few months. So the classification based on time is acute, subacute, acute less than 2 weeks, subacute 1 to few months, and chronic is after a few months. Okay, the classification, most common classification system which uses anatomic involvement, physiological class or the host type, and prognosis is the, all of us know this very well, it is the Cierney-Maeder classification. Cierney-Maeder classification. So in type 1, it is medullary osteomyelitis. In type 1, it is medulla. The medulla of the bone is in medullary canal of the bone is involved, medullary osteomyelitis. In type 2, it is superficial osteomyelitis. Superficial part of the periosteum and maybe the cortical bone is involved. In type 3 is localized osteomyelitis to a very small area of the long bone. It is a localized osteomyelitis. Type 4 is a more severe one, which is a diffuse osteomyelitis. Based on the host, so class A is where there's a good immune system and the patient is not immunocompromised. In group B, it is locally compromised, that is BL, or systemically compromised, it is labeled as BS. In group C, requires suppressive or no treatment. That means the patient is really immunocompromised and treating the condition may cause the patient to die, or probably the outcome is far worse than not treating the patient. So it increases in worsening, or the poor prognosis increases from class A to class C. Class A is the host has a good immune response. Class B is locally or systemically compromised, BL or BS. BL or BS, and class C is better not to treat the patient because the patient's systemic condition is so poor. The systemic factors which affect the class include, all of us know this, we have discussed malnutrition, alcohol abuse, immunodeficiency, diabetes mellitus, so smoking. The local factors which can cause problem include lymphedema, venous stasis, peripheral vascular disease, major vessel compromise, arthritis, extensive scarring, or post-radiation. So these are local factors which affect the Cierney-Maeder classification. So if the patient has a medullary osteomyelitis and a good immune response, it will be labeled as class 1A based on the Cierney-Maeder classification. If the patient has localized osteomyelitis with a poor or lymphedema of the limb with normal systemic of the patient, it will be labeled as class 2BL. So this is the Cierney-Maeder classification which gives prognosis. The higher the class, the worse the prognosis for these patients are. So how do these patients usually present to you in probably in your clinical exam? They present to you with a discharging sinus, may not be as big as this, but there will be a discharging sinus, and patient may have fever, but usually when they become chronic osteomyelitis, they don't have fever. And in young children with acute presentation, they may be lethargic fever and they may be in sepsis as well. Okay. And pain may be not very severe, localized pain may be there, tenderness may be there. If there is an associated fracture, crepitus can be seen. So these are very obvious physical presentation symptoms and signs that you can see. In the local area of the sinus, you should be able to see erythema, edema, and if you probe the sinus tract, it will go all the way up to the bone. So if you probe the sinus, it will go up to the bone. This indicates it is osteomyelitis. So these are some of the signs and symptoms of how a patient presents with osteomyelitis. You may have shortening of the limb. Patient may not be able to bear weight if there is a fracture. So you should assess thoroughly regarding this, and we will discuss this in another video regarding how to present a case of osteomyelitis. So what will you do initially? You will take an X-ray imaging. So you will take an X-ray in acute cases. Less than 2 weeks acute cases, you will not see any X-ray changes. Right? You need to lose more than 50%, 30 to 50% of the bone to be able to see on the X-ray. So in the initial 2 weeks, it is very unlikely that you will see any changes on the X-ray. Over a period of time, you will see osteopenia, bone lucency, a sclerotic rim, and then you will see a dead bone like this, which is more opaque or more radio-opaque than the surrounding bone. This is a dead piece of bone, which is called as sequestrum, a dead devitalized avascular piece of bone called as dead avascular devitalized piece of bone is called as sequestrum, and this forms as a nidus for bacteria to grow around it or cause infection around it. Involucrum is the new bone which tries to form around the new bone trying to form around the sequestrum is called as an involucrum. And the involucrum has multiple holes in it, which is called cloacae, and through which the pus discharge or granulation tissue comes out. So these are the terms that you must know very well. Sequestrum is a dead piece of bone around which new bone tries to form. It is called as an involucrum. And this is the inside portion of the sequestrum. Dead devitalized ivory type bone is seen. In between is a dirty granulation tissue with infection. You have small holes in the involucrum called cloacae through which the pus discharge occurs, right? So many times when patients come to us, they come with small bony spicules being spit out from the sinus tract, and this indicates that the patient is putting out sequestrum, and this is osteomyelitis. Various types of osteosequestrum are there. We will discuss this in the clinical topic, right? Where do you see, for example, where do you see ring sequestrum? You see it in amputation stumps or when external fixators are used, right? Where do you see black sequestrum? You may see black sequestrum in case of syphilis. You may see rice type of sequestrum in case of tuberculosis. So these are the various types of sequestrum which we will discuss in a later video. So you must know about this. This is what you will see in X-ray in chronic cases. You will not see this in acute cases. And only in chronic cases, after a certain period of time, when they lose 30 to 50% of the full decalcification of the bone occurs, will you be able to see osteopenia on the X-ray. So the other more methods, imaging methods include CT scan, which can be done to look at the sequestrum where the nidus of infection is, identifying the necrotic bone, etc. can be done with the CT scan. MRI is very sensitive and specific in acute stages. In less than 2 weeks, when you want to diagnose osteomyelitis, or in children, it diagnoses. It is very easy to diagnose this in acute stages. And in this, you will see in T2 sequence will show bone and soft tissue edema. And you'll also see what is known as a penumbra sign, right? Penumbra sign. You have heard of this with regards to eclipses. Penumbra sign. In T1 you will see a central dark abscess with bright internal wall and dark external sclerotic rim. So you will see a central abscess with bright internal wall and dark external sclerotic rim can be seen. So this is called the penumbra sign. So in early stages, very early stage, if you want to diagnose osteomyelitis, the go-to investigation is MRI. Nuclear medicine or bone scan can be done when radiographs are normal and MRI is not an option, but it is not usually done and it is not very specific or sensitive for osteomyelitis. What are the lab investigations you will do? You can do a blood test. WBC count can be done, usually maybe slightly only elevated. It will not be as elevated as other infections in chronic cases. Only in acute situation it might be elevated, and is elevated only in 1/3 of acute cases. The ESR is usually elevated, and it's usually elevated in more than 90% of the cases. CRP is definitely elevated, and it depends on the amount of infection that how fast it rises. CRP rises faster and falls also, but ESR rises later and stays high for quite a long time after treatment. Blood culture and microbiology can be done. Usually blood culture does not grow anything. Even microbiology and culture sensitivity also does not grow much organism. So we have to take it with a pinch of salt when we see a negative culture sensitivity and a blood culture report. So what are the treatment goals? Treatment goals, first thing is eradication of infection. And the second goal is stability of bone. And maybe in between a goal can be skin and soft tissue coverage. The last goal will be stability of bone, that is to obtain bone union. The last will be deformity correction and limb length discrepancy correction. So all these things are treatment goals. It's very difficult to achieve all of them in a 100% manner, and therefore we will have to make a lot of compromises regarding the goals of treatment that we want to do. Right, non-operative treatment is usually very rarely done, because once you diagnose osteomyelitis, the most important thing is to release the pressure, release the pus discharge out, so that quickly we are able to access the area of infection, and we can give local antibiotics and systemic antibiotics to clear the infection. In very rare conditions where we cannot do an operative management, we can give suppressive antibiotics. So these have to be long-term antibiotics and has to be given for a few months to even a year or so. So these has to be given, and usually antibiotics are given in IV form because a large dose of this do not reach the bone. So non-operative treatment is only palliative, and suppressive antibiotics only when required. The mainstay of treatment is irrigation and debridement, followed by organism-specific antibiotics. And you should do it as early as possible, as soon as the diagnosis is done. And you should do it in acute osteomyelitis, which fails to improve with IV antibiotics, can also be done. And in the very rare cases, you will wait and watch in chronic cases with antibiotics and patients who are not a good candidate for irrigation and debridement. So in irrigation and debridement, what you should do, it should be a radical debridement. All devitalized soft tissue must be excised. Soft tissue must be excised. All sequestrum, involucrum must be removed, and we should see for the paprika sign, right? You should see for the paprika sign. Until that time, you should remove all the bone, devitalized bone, and soft tissue. It should be done. All essential, non-essential hardware should also be removed, right? Once you get a bone gap, what do you do? Once you get a bone gap after you do a debridement of all this, there are multiple techniques in which you can fill up the bone gap. One of them is masculate, which we discussed in great detail in another video. The second one is vascularized fibula graft after the bed becomes free of infection. Vascularized fibula graft, right? And we may require plastic surgery help to do local flaps or distant flaps. Local flaps or distant flaps could be required. In the early stage, when we want the infection to clear, we can use antibiotic coated cement beads can also be used, right? So we use the cement, which is PMMA, and we have to use a heat resistant antibiotic. So amikacin, tobramycin, and certain other antibiotics are heat resistant, and so we have a small limited capacity of antibiotics which can be used for this. Nowadays we have absorbable calcium sulfate or stimulant can be used mixed with various antibiotics. This does not require curing via heat process, and therefore many different antibiotics can be used. This will provide local high concentration of the antibiotics, and this will prevent infection from recurring or clear the remaining infection as well. So we will discuss such things in more detail in appropriate places and chapters regarding bone substitutes, bone cements, etc. Right? We can also use the Elizarov technique for bone gap. All of us know this very well. Elizarov technique is an external fixator kind of technique which can be used for bone gap, filling up of the bone gap. So these are some techniques which we can use for clearing infection and restoring the bone gap after osteomyelitis surgery. So this is in brief about osteomyelitis and its management. Hopefully this helped you. Thank you very much. This is Dr. Kannan.